Support for this program is provided by the Foundation for Excellence in Louisiana Public Broadcasting and from viewers like you.
Hello and welcome to Louisiana Public Square. I'm Beth Courtney, president of LPB. We are so pleased to have Marvin McGraw with us tonight, a longtime journalist and friend. He's now the director of marketing for the Louisiana State Museum.
Well, Beth, you know, this is a very controversial and complicated issue at the same time. In January, Governor John Bel Edwards signed an executive order directing the Department of Health and Hospitals to pursue Medicaid expansion. An estimated 300,000 Louisianians would be eligible for coverage if it takes effect July 1st as scheduled.
Well, rather than debating whether or not to implement expansion, which we've been doing it may be time to investigate what folks will do once it happens. Would it affect already existing insurance plans? Would small businesses incur extra costs? What would happen to the state budget? Over the next hour, we'll hear from doctors, activists, and state officials as we explore these issues and more on effects of expansion, Medicaid in Louisiana. Medicaid expansion has been heavily politicized, but what are its repercussions in the real world? Governor John Bel Edwards would like to highlight how health care coverage would change the lives of working Louisianians. He touted his plan to the legislature on the opening day of the special session.
Folks like Butch and Dawn Schwest from St. Mary Parish. They're also here with us today. Butch and his family have made a living as professional shrimpers for generations. After the BP oil spill devastated their business, they could no longer afford their health insurance.
Right now in Louisiana, mothers, pregnant women, children, and disabled adults are eligible for Medicaid if they are under a certain income, but not the Schwests.
However, when they applied for Medicaid, they were told they didn't qualify because Louisiana had rejected the Medicaid expansion, which would have covered citizens like him.
Some working adults, no matter how little they make, are ineligible. Expansion would allow coverage for adults that make up to about $33,000 for a family of four.
Now, Butch and Dawn, they're not asking for a handout. They're asking for one of life's most basic necessities, decent health care. Health care that our tax dollars are already paying for.
What I think a lot of people don't understand, and what a lot of taxpayers don't understand, it's not that we're not paying for those people to get health care. We are.
Denise Botcher is the state director of AARP Louisiana.
We're paying probably the most expensive health care, and that is through the ER, through the hospital emergency rooms, the highest cost of care that you can deliver to an individual. So it's not like we're avoiding taking care of this segment of the workforce. We are.
If the state continues to pay for health care the way it does, money put up by the state, called the state match rate, would continue to rise. Under expansion, the federal government would pick up a much larger part of the tab. Frank Opelka Jr. is the chief of staff at the Department of Health and Hospitals. He says the state would also save money doing something called refinancing.
It's basically taking a person from the old to the new. So that's a big chunk of the savings. It's mostly pregnant women. When they have their baby, they'll come back on through expansion Medicaid. And if they get pregnant again or they need some other care, they wouldn't come back onto the old population. They come onto the new one, so we get the better match rate on them.
In addition, the state wouldn't pay hospitals by the procedure, as it traditionally has done. Instead, the state would pay a consortium of private companies to manage the care of Medicaid recipients. The group of 5 plans is called Bayou Health. The state pays those companies a certain amount to provide coverage. The companies then try to provide that coverage for cheaper than that amount. They do that by keeping enrollees out of emergency rooms, unless they really need it.
We even drive people to the doctor. We call people at home and we say, are you taking your medications? Do you need a ride? We make sure that we are managing their care to the fullest extent like they've never been managed before.
Jeff Drozda is the director of the Louisiana Association of Health Plans.
We're seeing dramatic outcomes and we're looking forward to Medicaid expansion because those 300,000 folks who are not in managed care will be.
Drozda says the plans are ready to handle the new enrollees, but there's a concern that there are not enough primary care doctors to treat them. Opelka says officials have been working with Bayou Health to address that for years.
When you do expansion, you don't actually add a massive amount of new care to the total system. What you do is you shift care from emergency to primary. So, you don't necessarily need a new base of providers. What you need is providers that do a specific kind of care.
Would expansion affect existing private insurance plans? Drozda doesn't think so.
There's going to be a very, very small percentage of individuals that might have private insurance that might become eligible. But for the average person who has their health insurance through their workplace or through the exchange or on an individual basis, it's not really going to impact their quality or cost at this point.
Botcher's organization recently conducted a study about the effects of expansion on small business. But what does AARP have to do with small business?
Well, you might be surprised, but a lot of our members who are 50 and older own their own small business. So they're living in rural communities across Louisiana, and they're struggling to make ends meet and make their business be profitable.
Expansion wouldn't just help business owners like Schwest get their own insurance. Botcher says it would ease their business costs by providing insurance for any low-wage worker he might hire.
When you have a healthier workforce, you're going to have a more productive workforce. So they're not taking time off from work because they've gotten so ill they now have to seek emergency room care. You're keeping them employed. You're keeping them building their skills. And then they can also take those skills and transition into a different job, maybe even higher paying job. That helps the economy.
And the injection of federal money that expansion would bring would have ripple effects throughout the economy, Opelka says.
You're basically putting about $1 billion to $1.5 billion into the economy, and then that grows from there. You're adding about 15,600 workers, most of whom are healthcare, which is a high-skilled job. So you're improving the structure of your economy, and you're also stabilizing funding from the state, down the line.
The legislature has fought against expansion for each of the last 3 years. It's unlikely to change its mind. Already bills have been filed in an attempt to weigh in on Edwards' order. In addition, lawmakers have the power of the purse. They could deny the federal funding. When making their decision, Edwards wants lawmakers to keep people like the Schwests in mind.
Those patients will then have greater access to primary care doctors and preventative care. It's a win-win for both health care and the budget because the cost of doing nothing is simply too high.
And joining us to explore the effects of expansion is our studio audience. It includes clergy members, law students, and medical professionals. We also have students from the Legislative Youth Advisory Council. Thank you everyone for being here. LPBS viewers and social media followers to participate in an online survey on tonight's topic. Here's a look at some of the findings. When asked what effect expanding Medicaid coverage would have on the state budget, 43% said it would be negative. 32% believed the effect would be positive. 25% said it would have no effect or they did not know. When it comes to small businesses, 31% of the respondents said expansion would have a positive effect. 25% said it would be negative. 44% said there would be no effect or that they did not know. And 44% of the respondents said expansion would have a negative impact on physician availability. 16% said it would have a positive effect. 40% said there would be no effect or they did not know. So let's get started. How do you think Medicaid expansion would affect our state? Will increasing the number of people eligible for Medicaid, is that a good idea or is it a bad idea? T. Bradley.
Well, Marvin, I think that the package did hit a lot of the very important high points. First of all, this is our money. This is Louisiana taxpayer dollars sent to the federal government. What we're talking about is reclaiming money that the people of our state have already paid for the benefit of the people of our state. The states that are accepting the Medicaid expansion are expanding the people who are covered, and these folks are using this money to buy private insurance, which then is used to pay providers, doctors, nurses, what have you, is $16 billion that's coming into our state that we simply aren't accepting right now. The states that are accepting it are building, as I mentioned, over time, a healthier workforce. Not to mention the importance of the care that what this means to the life of a family, but also means something to the life of our state's workforce.
Thank you, and I think Rob has some thoughts on that also.
I do. Just to add to that, I think it's about perspective. So how do you view health care? Do you view it as an option that only those who can afford it should have, or do you view it as a basic human right? And if you view it as a basic human right, then all those who are uninsured or underinsured should certainly have affordable and accessible health care, because it will help them, it will keep them in good standing, it will provide for their families, and at large, it will enable them to not just survive, but to thrive. It puts them in a totally different posture than otherwise not having health insurance would.
So is Medicaid expansion a good idea if this would cost the state more in the future in terms of Medicaid payments? Ryan, what do you think?
I think you have to look at the short term and long term. When you ask like the future, are we talking about a year, 2 years, or are we talking the future, are we talking 5, 10, 20 years? When we look in the long term, as the other panelists have already touched on, is that the long term is going to save the state of Louisiana money. You have a healthier workforce, you don't have people going to the ER. In the short term, it may cost in the front, but again, we're looking at the long term effects of this and the cost that is going to save Louisiana.
Well, Sarah, what about if someone is eligible under this Medicaid expansion and they do receive Medicaid and they show up at the ER? I mean,
at the ER, so as a physician myself, I see a lot of patients who come through. I'm an internal medicine doctor, and I see them in the hospital and in the clinic. If they see me in the clinic, let's say, for example, and these are just numbers I'm kind of coming up with, but if they're on a sliding scale fee, it'll cost them $25 for that visit to see me in one of our federally qualified health centers where they are subsidized to see patients who are underserved. For example, then if they see me in the hospital, if they get admitted to the hospital and they see me there, that hospitalization would cost them probably, so in between that there are urgent cares that are usually, let's say, if that first visit is $25, the next one's $150, the next one in the hospital is upwards of $1,000, $5,000.
But let me ask you, is the ER the place that we want these patients to go?
Absolutely not. Absolutely not.
And there's an educational component to this.
Exactly. You have to catch them in the front, as they were saying in the package, that they need to talk about patients coming to see their primary care physicians to prevent them from the expensive care in the emergency departments.
And Bobby, I think you wanted to weigh in on that.
You asked a question about paying more.
Right.
If more people are through expansion or on the rolls. Well, I think we're going to have to pay more anyway, because if you look at the disproportionate share hospital funds, which are expected to be phased out in 2020, it'll cost almost double to see a patient if we don't expand compared to if there is an expansion. You know, a little over $600 a patient a year compared to a little over $1,300. So, you know, what we end up with is hopefully a healthier workforce. And we're talking about poor people now who can't afford it. By expanding, giving them the opportunity to be able to be covered under a health insurance plan.
So, Gregory, you wanted to
Yes,
mention?
I do agree that education will be the component that's necessary to educate the public so we don't go run into the emergency room. However, I have a concern that the clinics need to be certain that they are adequately equipped to be able to handle whatever the individual walks in with. I recently walked into a clinic, thought I had just a stomach ache. I was in there about an hour and a half, and they didn't have the necessary equipment to do the x-ray that was needed. I ended up having to go to the emergency room anyway, only to find out my appendix had ruptured. And so while I'm sitting there waiting in the clinic, hoping that something could do, because I felt like I'd been educated. This is not life-threatening, is what I thought. But as it turns out, it was. And so we've got to be certain when we shift the responsibility from the emergency room that the clinic is adequately equipped to handle what walks in the door.
So what kind of impact would Medicaid expansion have on the state's hospitals? I mean, you've all seen the news that our safety net hospitals, which have been privatized, are in trouble. When you add an additional 300,000 people to the Medicaid rolls, what does this do to the system? Heidi?
Sorry. They're actually going to be reimbursed for the care of that person. Right now, most of the people who are going to qualify for Medicaid expansion are uninsured, or as we call patients that don't have insurance, quote, self-pay. In other words, the hospital may or may not get any reimbursement, because if somebody doesn't have any money at all, they're not going to be able to pay that back. 1 out of 5 millennials lives in poverty, and probably even higher here in Louisiana, and this can be a huge burden for a young person. Not many young people coming straight out of high school or even college are necessarily going to get a job that has decent health benefits, and so Medicaid expansion is really going to help young people as well as people that are older, so they don't end up with a huge debt and medical issues that could have been addressed before they
Dr. Sirk, I think you wanted to weigh in on that.
It seems to me it only is going to help the hospital's bottom line, because when Charity, our local Earl K. Long Hospital, was closed, it was a snowball effect. The next thing that happened is the general closes, because they cannot pay for all of these indigent people coming in. And so ultimately somebody's going to pay for that, so it's moved now to another part of town, and the people who are insured over there are paying for indigent care at those hospitals. And I think that a model that actually could be used is what's happening where I am. I'm now LSU Lake, and the Lake has a very good system of social workers, patient advocates, where if patients are frequent flyers at the emergency room or the urgent care, they find those people and they call them and they figure out why is it that they're not coming into a primary care doctor.
You know, Marvin, everybody's touched on something very important. We talked about the Medicaid reimbursements being lower than other reimbursements, but it's more than nothing, as you just said. And so what happens if these patients aren't part of the payment mix, that financial burden shifts, and when a facility can no longer handle that, it closes down, not just for the poor people, but for everybody, private payers, insured, and what have you, and we just have less access.
So let's, you bring up a good point. So let's say we bring 300,000 new Medicaid recipients into the system right now, and you do mention that it does pay lower than the cost of service, Medicaid does. Consequently, you have physicians who are not taking these patients or are limited the amount of patients, Medicaid patients, they will take. What kind of impact is this going to have on the system?
I'd like to speak to that in one way, saying you keep talking about these 300,000 patients who are going to show up in the system. And Dr. Sinclair was just saying, and Dr. Sirk, these are not new patients.
Right.
They're not new human bodies. They're going to suddenly
What you're saying
appear.
is they're gone somewhere.
No, they are already going to those hospitals and clinics,
right.
and no one's getting paid for the care that they're being provided. So they're not new human bodies who are suddenly coming up from the bayou and arriving, asking for care and saying, I heard there was expansion in Louisiana. I'm so excited. I've needed a doctor for years. No, these are patients who already come and see us in the clinics and in the hospitals. That said, so for some of those hospitals, specifically our safety net hospitals in Louisiana and our FQHCs, federally qualified health centers throughout the state, those services are already being provided, and they're not really being reimbursed at all. And if they're reimbursed at all, it's for a very, very small amount of money. However, there are certainly parts of the state where some of those 300,000 people are not seeking care. And those are the areas that are very, very, very worrisome here in Louisiana. And I know that we have some of my other physician colleagues here who run some of those clinics who are very worried about that bottom line. And I think that is a very important question, but it's a smaller piece of the puzzle than other people think when they anticipate the impact on the larger system. But it's certainly an important one.
Hold that thought. That's all the time we have at this portion of our show right now. When we return, we'll be joined by a panel of experts to further explore effects of expansion, Medicaid in Louisiana. And welcome back to Louisiana Public Square. Tonight we're discussing Medicaid expansion in Louisiana. Joining us now is our panel. Mr. Michael Bertaut is a financial modeler and forecaster with Blue Cross Blue Shield, currently responsible for predicting membership activity for the 1.6 million Louisianians who carry a Blue Cross card. Dr. Rebekah Gee is the newly appointed Secretary of the Department of Health and Hospitals for the state of Louisiana. She formerly served as the state's Medicaid Medical Director. Mr. Stephen Wright is President and CEO of CHRISTUS Health Louisiana, with hospitals in North, Central, and Southwest Louisiana, as well as Southeast Texas. His oversight of over 1,200 beds throughout the Louisiana and Texas facilities. And Dr. Gary Wiltz is Chief Executive Officer of the Teche Action Clinics, a network of 10 federally qualified community health centers, FQHCs, which serve Medicaid patients. And we thank you all for joining us. And before we go to the audience, tell me how Medicaid expansion will affect your organizations. And let's start with Mr. Bertaut.
Thanks, Marvin. At Blue Cross, because about 1 out of every 3 people in the state right now is walking around with a Blue Cross card in their pocket, it's inevitable we'll have a little overlap when there's a big coverage expansion. Our mission is to protect and defend the health and lives of people in Louisiana. We want to improve their positions. And so we are looking very closely at understanding where we have overlap. We have identified, for example, 20,000 individuals who are going to buy insurance through healthcare.gov and will become Medicaid eligible. At that time, when they go back to open enrollment, they'll have to move off of private coverage and on to Medicaid. But that's just a small sample compared to the 300,000 that would be covered under the addition. We are ready, willing, and encouraged to get out and help this expansion succeed.
And Dr. Yee, you were the state's Medicaid Medical Director. You have intimate knowledge of this subject. What kind of impact is this going to have on Louisiana and your organization?
Certainly. So one of the challenges we've had in the past few years is that we've not expanded when the federal share was 100%. So one of the things we want to do is expand quickly so that we can take advantage of the maximum federal share. So one of the things that will be great for my department is all of a sudden we'll be getting a lot more federal dollars and a lot less cost per individual that we cover. And right now we get about 62 cents on the dollar for every dollar and we spend about 38 cents on the dollar. In the future, we'll be spending at a maximum 90 cents on the feds will be spending 90 cents on the dollar, and we'll be spending 10 cents. So that's a much better deal for us in terms of our economy and our DHH budget. The other thing in the long run that I hope for and that I think Medicaid expansion will allow us to do is to have healthier people. You know, as many of the physicians on this program have already described, people are already getting care. They're getting it in the emergency rooms. They're getting it once they're very sick. They wait. They delay their preventive care. As a physician practicing obstetrician, I have seen that myself. Women delay mammograms, women get sick and come in way too late to unfortunately prevent that disease from progressing. So we're going to be seeing healthier people in Louisiana, and that's a very exciting prospect.
Very good. Mr. Wiltz, your hospitals, you have some rural hospitals, you have some urban hospitals. What kind of impact is the Medicaid expansion going to have?
You know, for us, CHRISTUS Health is a faith-based Catholic organization, and it's really a social justice issue. You know, from a social justice perspective, we believe that people should have appropriate access to health care. And you can't imagine what it would be like if you've never had a card in your pocket before, when you can actually go to the doctor and pull out that insurance card and be able to get services. And the truth of the matter is today, many people avoid those services because they're scared. They're scared that they won't have money to pay. They're scared that they will make a bad decision. They're scared that it will bankrupt them in terms of the ability that they have to pay long term. So that's one of the factors for us as an organization. The other factor for us is we're going to pay because when the Accountable Care Act was passed, there's a certain percentage of the funding for that act that is going to reduce the amount of money that we receive through Medicare. And so our DISH dollars and our UPL dollars are going to go down. And for the state of Louisiana, those are huge numbers. So we're already paying money federally and giving up dollars. So why shouldn't we take some of that money back and be able to use that money for the citizens of the state?
Very good. And I want to apologize. I misnamed you, Mr. Wright. This is Dr. Wiltz right here. That's so thank you very much. And my apologies. So your clinics, what kind of impact is it going to have on your clinics?
Well, it's going to have a tremendous impact, and just like the other panelists, I can only see the positive benefits that are going to occur. It's very personal for me because I've always felt that health care is a right. I was born at Big Charity Hospital in New Orleans. trained. I was trained at Tulane Medical Center. I'm an internist. And to watch other states, I just had the honor of serving as chair of the National Association of Community Health Centers, serving some 28 million people nationwide. And to see other states and to have to go give talks in California and Minnesota and places where we've seen the impact that this has had on those states that did expansion. And then, you know, unless you are a physician sitting in a room with a patient and to have them go through the process and to be told that if we had taken Medicaid expansion, they would have been covered, and to see the reaction that they've had that they were not, just for all the reasons that you mentioned. It's the most disheartening, deflating feeling is that you know what they need, and we can provide, and we do provide extremely good primary preventive care and community health centers. But when it comes to the next stage, and I can't divulge because of HIPAA laws, but when someone has a problem, and then we need to refer them to a hospital to get secondary and diagnostic workups, it's not a matter of if we're going to treat them, but how. I had a patient in last week, a young woman with rheumatoid arthritis, that when she first got diagnosed wound up in the emergency room and ran up a $10,000 bill. And now she's getting letters from the collection agencies, and her credit is ruined.
Wow.
At 23, because she didn't have a means to pay for it. So it's going to have a tremendous impact. Numbers-wise, 300,000 people that we're taking care in community health centers, 120,000 have Medicaid. We've already projected and have staged. We know who they are. There are about 80,000 in our system right now that are going to benefit from that.
Well, thank you very much, Dr. Wiltz, Mr. Wright. Let's go to our audience for some questions, and I believe Dr. Valentine had a question about reimbursements.
Yes. You know, I'm a primary care physician, internal medicine and pediatrics, and as a private practice physician that accepts Medicaid from all of the Bayou Health plans, I'm really interested in knowing if any of the extra, the federal dollars that we would get from expanding Medicaid would go to looking at the reimbursements for not only primary care physicians, but for specialists as well, because I completely agree with you that we spend a lot of time looking for that specialist that will accept our patient.
Well, let me just say this, because, you know, no matter how altruistic you are, and I think we all went into medicine for the right reasons to help people, but you go bankrupt being altruistic if you don't have a means to pay for the care that patients have. So someone may be able to scrounge up $100 to, say, an initial visit. Then when they're in the exam with you, exam room, and they're uninsured, and you know what they need, the cost of the labs, medications, the workup that you want to do, there's no way to, so it's a helpless feeling as a provider. So you can't do it out of altruism. So I had the honor of co-chairing the governor's healthcare transition team. One of the points that we made and recommended is that the Medicaid reimbursement rates for the private sector try to reach the Medicare rates. That's the goal that we have suggested. Now, I don't think we can get there immediately, but that is the goal. And I think when you increase the rates, then you'll have the private sector participating more. Because we have a workforce shortage, you have to get everyone, all hands on deck, to try to solve this problem.
I think Bobby wanted to weigh in on that.
Dr. Gee, I'm a retired state employee, DHH, 39 years, Office of Public Health, and now an AARP advocate. You know, I know how the legislative process works. So the governor issued an executive order directing DHH to begin the implementation process, and I'm assuming that DHH is on the road to doing that. Governor Jindal was opposed, and so the legislature didn't go there. And so I'm wondering, what role is this legislature going to play in that process for expanding Medicaid? Or do you know?
So, Bobby, today I had a lot of meetings with legislators, and most of them were positive. I didn't get a single no. And today I met with some folks who some of them were new legislators, some of them were Republicans. I think when you look at the numbers, you look at the $1.8 billion additional a year that will come into the state, you look at the $120 million additional tax dollars that come into the state, you look at the fact that we're already funding unfunded care in the state and that the federal government is going to take that away eventually, and we're going to lose the funding for our rural hospitals that will have to close. And they won't close just for Medicaid, they'll close for everyone. When we look at the fact that 70% of the people that will get Medicaid will be working folks, people like the shrimpers, people like the fellow who was unloading helping me unload my car at Sam's Club the other day who has a minimum wage job and a child and is trying to do the best for his family but can't afford insurance. Those are the types of people that get coverage expansion. And so when you sit down with legislators and you have an honest talk, if they're willing to listen, which not everyone is, but most are, because they're there to serve the people. Most of our public servants are there to do a good job. They're there because they care about people. And when you look at the numbers, and again, what we're about in the Edwards administration is showing the real numbers. We're not about inflating numbers or having unrealistic assumptions. We put realistic assumptions in our model. We know that it works for the state, and it works very well economically for the state. And again, even the most conservative to liberal, you have the social justice argument on the liberal side, and on the conservative side, you have the fact that it helps the state economy, and we sure need that right now. So I'm very optimistic.
Well, thank you very much. I'm sorry, go ahead.
I think part of the problem is that for at least 2 to 3 years running, we've really had misinformation that's been shared across the state. And so that's one of the factors. The other factor is that we just have so many people that are uneducated about the financing system and how it works. Quite frankly, it's very complicated. And so it's very difficult for people to get a grasp of and understand. And so I think that part of what has to happen is we have to do a better job of educating all of our citizens across the state, and quite frankly, not just the legislature. If you looked at the survey that was showed as we started the session today, one of the things it showed is that general business people aren't sure. I mean, it was like 44% uncertain. They don't have the facts. They don't understand the information. They don't understand how the funding works. And to Dr. Gee's point, previously they'd only been told what it was going to cost the state. It was going to cost the state this much money. No one ever said how much the state was going to receive from the federal government. And quite frankly, because we didn't do it for the last 2 years, we actually gave up about $500 million. I mean, given where we are as a state today and what budget deficit we say we have, if we'd have had that $500 million, we might be in a lot different situation today. And so it's, we've got to make different decisions, I think.
To that point about getting people educated, Dr. Richardson from LSU just did a great study that was just released this week that puts a lot of that information out there for people, to digest, and those are the real numbers, so.
It's a great study, and I think wasn't it funded by AARP?
Yes, co-funded.
Co-funded. It's a great study.
So we have some members of the Louisiana Youth Advisory Council. I want to bring them into the discussion. Thank you all very much for being here. And I think Maria has a question about affordability.
Yes, so due with the $1.6 billion deficit here in Louisiana, how exactly is Medicaid? Because you said that it was 90 cents coming from the federal government, but what about those 10 cents coming in from the Louisiana taxpayer dollars?
Sure, so the 90 cents, it doesn't go down to 90 cents until 2020. And in the meantime, what I mentioned earlier is we get an additional $1.8 billion a year in additional revenue. So some of that is going to hospitals, some of that's going to physicians, some of that's going to the cleaning staff, some of that $120 million is the additional tax revenue that's collected on all the folks that you need to work and staff and take care of these folks in different ways. And so it does make sense if you look at the economics, even if at 450,000 people coming in. So some states have underestimated the number of people. So even in our economic argument, we've looked at, let's say it's not 300,000, let's say it's 450,000. We still save money. So it is a good thing for the state. In other words, what it does is it brings in more money, more revenue to the healthcare system that allows us to stabilize that budget. As you might know, one of the problems with our Constitution is we constantly have to cut healthcare and education, the two most important parts of our state, the ones that ensure that we have a healthy future. And what expansion money does is it helps stabilize. And again, what we've talked about a lot is right now we do pay for the care for the uninsured, right? And our physicians don't get paid for that. This allows them to have paying patients coming in. So it helps us stabilize so that hopefully in the future we'll avoid the types of cuts we've had to experience for a decade now or more.
That's true.
Maria, I like to look at the program from the private side as an economic development project. As a state, we've engaged in a lot of different types of tax credits and things to help boost our economy. But it's rare that we can invest $1 and get a guaranteed $9 return in any kind of economic development project, and this one just happens to be completely focused into the healthcare sector. Now, whether those healthcare providers can pay bills or turn a profit on what it pays, that's something they've got to work out for themselves. But from an economic development perspective, those $9 are going to find their way back into the economy. Certainly some of those entities are going to be tax-paying entities, and it's going to get recaptured at the legislative level. It's going to happen.
Sarah, you want to?
I just wanted to add anecdotally one extra piece to the economic puzzle, and that's that I personally have a lot of patients who cannot afford their health care right now unless they have Medicaid. And in order to get Medicaid, as we saw in the clips before, you have to be a child or a parent or a pregnant woman or disabled. Now, the demographic that's completely missing there is working single men, right? Working single men are completely left out of that algorithm. And then if you remember, when we expand the eligibility, it expands to $33,000 a year for a family of 4. So if we think about what that means to make $33,000 a year for a family of 4, that's still not a lot of money, right? We are not paying people who make millions of dollars a year to have free health care. These are patients who then have chronic diseases like diabetes. They come into my clinic. They cannot afford their insulin because insulin by itself, unless you have patient assistance programs, is $200 a month.
Correct.
Now, in order to pay for their insulin, they can't pay for food, or they can't pay for housing, or whatever else it is, anything really. You can't afford anything else if you're trying to pay for your chronic medical conditions. And they come in and ask me if I can fill out their disability paperwork.
Right.
And now, ethically, what do I do as a physician? Do I fill out the paperwork and say, okay, I actually think that this guy's going to die if I don't do this? But then on the other hand, I'm thinking, I'm completely taking him out of the workforce. He is now no longer legally allowed to work in this state because then he loses his disability. So in addition to the revenue that we're going to get by investing the $1 and getting the 90 cents back, we are pulling people back into the workforce because they will no longer have to claim disability in order to get their Medicaid.
Yeah, and as a practicing physician, I can say I can't agree more with you. We are incentivizing the wrong types of behavior. What expansion is incentivizing is folks to work. And a lot of our workers in the state are, they're farmers, they're fisher folk, they're in the food service industry, they're in the entertainment industry, they're in the cleaning industry, hotel industry. Many of those industries are minimum wage jobs. Those folks with kids, they qualify. We want to incentivize them to continue to go to work. So it's a program for working folks.
Well, one of the recommendations was that we educate Medicaid recipients of the benefits of what that means. And of course, lifestyle is a huge problem. I think an unintended consequence, I heard Mr. Kennedy talk about closing all the festivals, funding for that. That might improve the health for short term. The model of Louisiana, as you know, is union justice and confidence. It might as well eat, drink, and be merry. And so it's a challenge. But to your point, lifestyle and Medicaid education of those patients and recipients, and getting them into a primary care medical home, which is the hallmark of what we try to do in FQHCs, where it's not only just one physician taking care of a patient, it's a whole team of providers. So it's really the best of both worlds, and so there is going to be a bump in cost. We talked about that because you're going to have people that are previously undiagnosed, hypertensive, diabetics, that are going to be coming into the system, utilizing it. But in the long term, when we get them under control, it's going to save the system a ton of money and improve the morbidity and mortality rates over time.
Very good. Ryan, you had a question?
Yes, it was a question kind of piggybacking on what you guys are already talking about. I came from California as a community health worker, so when California rolled out the plan, I was a part of that team. That being said, we've talked about expansion, but I want to talk about the quality of care. Is there anything with Louisiana rolling out that you guys foresee that we're going to make sure that we provide culturally relevant and competent quality of care? Because as we know, when the person is providing that care, they're more likely to receive the best care they can have, and they're more likely not to come back into the system.
Well, the whole thing is going from volume to value. And we have to report, we just finished our reporting requirements, those who work in FQHCs. We have to report out to the feds how we're controlling folks. But I'll relate something you can relate to in California. My son works for Kaiser Permanente, actually on the East Coast, and they have the HEDIS measures and the quality measures, and that's how they are evaluated. Not on how many patients, but how well did they control their panel. So how many patients that needed pap smears, mammograms, colorectal cancer screening, how many got flu shots. I mean, it's a whole quality issue that you're not just seeing patients or throwing money at it, but you're actually improving the clinical outcomes. So that has to be a component of it, because otherwise you're just throwing money at a problem.
So let's go back to our youth leaders here.
I come from a small town, like 2,000 people, and we have a small regional hospital. And recently the ER has been open for back and forth, open and closing. And the biggest way to make Medicaid work is to educate the people not to use the ER. And when this ER closes, the nearest one's 30 miles away. So my question is, what would it take to educate these people to make them go to the primary care physician rather than the ER, and what would it cost be, because we're already in a severe deficit?
A couple things we can do. One of the things we're doing is planning on implementing a copay. So if a patient goes to the ER, they really don't need it, they get assessed a copay and retrained. Another thing that we've been planning on doing is a statewide outreach in barbershops, beauty shops, and churches, just to educate people. And our system here has been one of the last historically remaining charity systems, and having worked in that charity system, I know that the traditional system meant, hey mom, come in at 8 a.m. as an obstetrician, you come in at 8 a.m., wait till 1, hope you be seen, you don't have an appointment time. And so folks got used to either not showing up, they weren't also getting that respect, that cultural competency about their time and their needs. They were just meeting it because it was a charity system. We've got to retrain the docs about cultural competency and respecting the Medicaid patients, treating them the same way, because people are people, but also training the patients to say, listen, you have another option now. It's not just the ER. And what I see is with the additional revenue coming into the state, there will be innovations in terms of urgent care centers, after-hour clinics, because again, we're going to be focusing on working people. Working people need to get care after hours, and we can do that in a much cheaper way. In fact, United Health was here talking to me yesterday. Across the country, for a quarter to a third of what it costs to have an ER, they can do an urgent care with an ER doc staffing it. So these are all the types of models that will come. But right now, because we have such a high proportion of non-paying patients, free care patients, there's really not the incentive to develop those models. So it's going to have to be retraining for the docs. It's going to have to be a retraining for the patients, and then we're going to have to do innovation in our system to create the models of care that work for the new patients as well.
So one of the questions is as we expand Medicaid, how can we ensure we have adequate providers to treat these patients? I believe Dr. Sinclair had a...
That was my question. It's all well and good to say don't go to the ER, go to your primary care doctor, but we need to have those primary care doctors available. And what's the plan to attract more providers into the Bayou Health system?
Well, I think one of the things is that you have to look at the team approach, as I mentioned earlier, and that includes not only physicians, but nurse practitioners, physician assistants, and the part of the team that actually can help expand. And the ratio of physicians to collaborating, practices where you have physician assistants or nurse practitioners, that's been a tremendous part of the strategy that we've used in community health centers. These mid-level providers can provide a lot of that care. The medical schools have increased some of their class sizes. The residency programs have got to increase the number of slots and dedicate them to primary care providers. And we've got to incentivize primary care in this country. When a kid, most of us go into medical school, when we get in, we go with the right reasons, then you get jaded. When that debt starts piling up, you start thinking about, maybe I ought to do a subspecialty just to pay off the debt. And that's most of them wanted to do the right thing, but that does play a role in the match is coming up next month, and that plays a role in what specialties people are choosing. So we've got to incentivize them.
Marvin, when we talk about retraining, one of the things I'm very encouraged with Dr. Key said about talking to legislators and getting a positive response, because we definitely need legislative retraining with the attitudes on this over the last couple of years. I mean, I followed the legislature closely, and legislators that under the banner of fiscal conservative would not vote to expand Medicaid because it would cost $1.6 billion over 10 years. They never mentioned that it would bring in $16 billion, a nine-fold return. And then the next breath, they would award a $2 billion tax credit to an industry that would not break even. So it's very encouraging to know that they're looking at that equation and for for what it truly is.
Can we go back to the provider question?
Oh, sure, absolutely.
One of the things, Heidi, I think that we're beginning to see, quite frankly, is you're seeing health systems step up to the table and actually are employing providers, especially around primary care, to ensure that there's access. And whether it's a commercial patient, a Medicare patient, a Medicaid patient, quite frankly, or the uninsured patients, because they know that they need a better system and model of care in order for us to be able to keep the system running that we all love and appreciate. And so we've hired a number of primary care physicians in that regard. The other thing that's happening, and again, it doesn't matter what patient population we're talking about, but we have to get comfortable with extenders. We have to get comfortable with patients going to see nurse practitioners and PAs, which is what happens in the FQHCs. I mean, that is a big key portion to their model. It's what happens in rural health clinics. It's a requirement that you have those extenders in those rural health clinics. CHRISTUS is the largest provider of school-based health centers in the state. We partner with the state. We have 25 of those centers across the state where we care for those kids, and those are staffed by extenders. And we give excellent primary care in those locations, but we couldn't afford to employ physicians in all those locations to care for those kids. They're supervised, obviously, by physicians, but that's a way that we'll do it. But the health systems are stepping up and making a difference.
I also think there's a lot of time and energy that physicians are wasting on things that would be better triaged to case management, for example.
So that, and then you heard the discussion earlier about a team.
Yeah.
So if we're talking about diabetic education, well, let's have a diabetic educator that's a part of that team that's doing that, so you can go do what it is you need to do. You know.
And Ryan, you want to weigh in on that?
You kind of touched on that. Is that a part of that team that I was a part of? We had healthcare educators. We had all these different things going on. But to that question, to that point, is my question about doing a needs assessment. He talked about the rural areas. I spent a lot of my time in Scotlandville. And so in Scotlandville, is there, with this expansion, is there things set aside to where we can look at through a needs assessment where there are pockets where there's a lack of not only access but quick access, you know, where you don't have to take a 10-15 minute ride to get access to care. So we know the further you have to go, the less likely you are to come in. Is there money there to where we have people doing mobile health clinics and all those things there? So is there a needs assessment to find out where these isolated pockets are where there isn't access to health care?
Well, I think you have to craft it on the region that you're in. You know, every hospital has a needs assessment. We do it. One of the things we haven't done well is collaborate and then figure it out. You can't craft the solution out of D.C. or out of Baton Rouge. It has to be drilled down to the local parish level and regional level to have the effect. No one knows the people. That's why I have the greatest respect for local elected officials, because they know where you live, worship, and how to find you. But they understand the population and the pattern that you're talking about. And I'm sure that you did patient navigation too. So I think that was one of the unintended consequences here in Baton Rouge, you know, for women trying to deliver. I don't think it was a lot of thoughtfulness that went through that a woman would have to take 2 bus transfers to get to a hospital. That was not thought out. So I agree with you. It has to be done, and hopefully we will do a better job of looking at you know, those needs assessments.
Well, let me ask the panel this question. I was at the Capitol today at a House committee hearing, and our new Attorney General, Jeff Landry, was talking about Medicaid fraud. He says it's a significant issue in Louisiana, as it is across the nation. How can we ensure that this money is going to be spent responsibly and not have the issue with fraud, which is apparently costing the state a significant amount of money?
Let me say this about fraud. I think fraud is somewhat of a red herring. I think people that don't like expansion want to just put fraud out there and say, oh, it's fraudulent. Let me just say this. I've never met a patient that was asking for a service they didn't need. When we talk about fraud, we're talking about fraud, waste, and abuse. And what we're talking about often is just miscoding. So a clinician, doctor, nurse puts down the wrong code about what was done. It might not have been that it didn't need to happen. It's very hard to measure. Just about any industry, whether it's Walmart, Walgreens, every business has to that's in a has a product has to assume there's going to be a certain amount of product lost or fraud. And we don't have any indication to think that Louisiana is any worse than anyone else. The numbers are difficult to pin down. You have national estimates around the 5% range. You have a RAND study that's 3, 6, or 10%. And again, we take it very seriously. On my first week on the job, I replaced our director of program integrity, moved it into a different office. I have made it very clear that we are going to prosecute folks who are not doing the right thing, and I'm very excited to recoup the money from them. But I want to make it clear that that process takes a long time, and that is not a panacea, and that is not the way we're going to solve our state budget crisis, and that beating down the system, that we have fraud in it, just like every other business industry, is a red herring. There's fraud in white-collar fraud, folks at the banks. There's fraud in just about every industry, and we could just say, well, we can't do any business because of fraud. That's not a good reason not to step up and do the right thing and expand Medicaid. And I'm kind of, in a way,
you're very passionate about
yeah, well,
this
I'm tired.
issue.
I hear about it a lot, and but I take it very seriously. But again, let's address it, but let's not use it as an excuse not to do the right thing.
So, any one of the other panelists want to weigh in on this?
I found it fascinating that a few years ago, the Government Accountability Office did estimates of fraud, waste, and abuse in the Medicare and the Medicaid system. And the number was gigantic, $60 billion a year, something like that. So there was a national survey done by Kaiser, and they asked people 2 questions. Number 1, do you believe there's fraud, waste, and abuse in the healthcare system? And 86% of them said yes, absolutely, it's there. Then they asked them, have you ever had care that you thought was unnecessary? And 7% said care they've had unnecessary care. So in other words, unnecessary care is something that's done to somebody else, right? But if it's being done to me, you doggone right it's necessary. I'd like to have that care, please.
Let me just follow up on that, because those of you who are practicing physicians, when you order, and particularly in durable medical equipment, it used to be that you can order walkers, you could order oxygen, you can order things that were needed. I can tell you right now, there's so many regulations that you cannot write a script, and I see a lot of heads nodding. There's a lot of regulation within the system that is, I think, curbed just carte blanche writing for something. You have to really document the medical necessities. The system's in place.
So the bureaucracy has grown.
Yeah, well,
extensively.
It's in place. You
Right.
know? So those who are concerned about fraud, let them come and walk in our shoes for a day and try to get some of the things that we have to get for our patients. It is regulated, so it's being watched.
And by the way, Bayou Health, which is our managed care reforms that happened several years ago, is about bringing managed care to Louisiana, which means that we have companies that only get paid a certain amount per patient. They lose money when there's fraud and abuse. So we have not only the several layers in the government that are working on fraud, but also the companies that manage care have a great interest in making sure it's not occurring and recouping when possible. So we have multiple layers on this issue.
Sarah?
I was wondering if we could sort of talk about Bayou Health and the unique space that we're in Louisiana with Medicaid expansion, because there are very few states that have anything close to a privatized Medicaid system, and those that do exist are kind of new in light of the ACA and some of the Affordable Care Act expansion throughout the country. I'm really interested to see what Louisiana has planned for ways that we might eliminate the churn that I think Mr. Bertaut was talking about earlier, where people kind of go in and out of eligibility for things, whereas there are some of his clients right now who already are on his BCBS plans, and they might churn into the Medicaid plans once they're newly eligible. But because we have Bayou Health, we have a set of private health insurance companies that provide our managed care plans from Louisiana. And that's a really unique situation that we have that may make it easier for patients to stay covered in a way that's unthought of in some other places. Has there been any thought to ways that we can decrease what people call churn?
I'm excited about the opportunity for Medicaid to finally establish just a fixed income line at 138% of the federal poverty line. It's a general category. It's not a collection of special needs, which is what Medicaid wrestles with now, so that a young adult who works 35 hours a week and makes $9 an hour and is a single doesn't have to try to come up with $100 a month to cover his boss's health insurance plan, which probably has a $3,000 deductible that he'll never be able to pay. Now, because we didn't embrace Medicaid early on, we've got this bizarre situation now where healthcare.gov, the website, had the authority to issue money all the way down to people who made 100% of the federal poverty line. So those 100 to 138s weren't really supposed to exist in the original health care law. And they have the best health insurance on earth. $19 a month, no deductibles, no copays, broad PPO networks. So we've got to figure out a way to communicate with those folks, because the statute says once they're aware they're Medicaid eligible, they're not supposed to take any more money from the government for their health insurance. Now, we won't know that they're Medicaid eligible, but at the next open enrollment, if we get this thing rolling on July 1st, at the next open enrollment, they're going to get an ugly surprise. Their Blue Cross card's going to go away and be replaced by a Medicaid card. And so we don't want that to be some big traumatic event for them. In addition, we know there are probably another 100,000 folks out there who are working very low-income jobs, who would be subject to a fine for not having insurance. And the federal law under PPACA, the affordability requirements really don't work for anyone who makes less than about $20,000 a year. So if they make less than that, they'll become Medicaid eligible. It's a much better fit for them than trying to struggle through private insurance. So I'm not as worried about that churn, because I think once they realize which program is best for them, and it'll be Medicaid for the lower income folks, they're going to be much better off in managed care and in a program that fits their income.
Well, we've run out of time for our question and answer segment, and we'd like to thank our panelists, Mr. Bertaut, Dr. Guy, Mr. Wright, and Dr. Wiltz for their insight on this month's topic. When we come back, we'll have a few closing comments.
Well, Marvin, I learned a lot that I didn't know
absolutely.
tonight. We could talk about this topic a lot, and I think a lot of people in Louisiana are going to find out some more. Rather than having the conversation about the politics of expanding or not expanding, this has a lot of permutations that are going to be interesting as it evolves.
We'll be talking about this for a while, no question about it.
And when you become more mature, as some of us are, you spend a lot more time thinking about hospitals and doctors and things like that. And so I think it's of great interest to everyone. So great conversation.
Thank you, Beth. Well, that's all the time we have for this edition of Louisiana Public Square. We encourage you to visit our website at lpb.org/public square. And while you're there, take this month's survey, view additional sound bites and comments on tonight's show. And we'd love to hear from you, like we did following last month's program on police body cameras.
Yes, PW wrote to us, I'm in full support of the use of body cameras by police officers. It holds the police accountable.
And Concerned Citizen writes, let the police do their jobs. What if it were mandated that every citizen in America had to wear a body camera? I'll tell you, they would not like it.
And Susan writes, I support our police, and I also support families who've had tragic situations due to lack of good judgment. Body cameras will tell the story in truth. Well, we hope so. You know, on next month's Louisiana Public Square, we'll delve into the Louisiana shortage of funding for public defenders. Districts around the state are struggling to provide those who can't afford an attorney with their constitutional right to an adequate defense. Tune in Wednesday, March 30th for Justice on Hold, Louisiana's public defender shortage. Thanks for watching, and good night.
Good night, everyone.
For a copy of this program, call 1-800-973-7246 or go online to www.lpb.org.
Support for this program is provided by the Foundation for Excellence in Louisiana Public Broadcasting and from viewers like you.